But just wanted to thank everybody for being here today. Hopefully we can teach you guys, make this useful time spent on learning something and how we can improve the care that we provide out in the field. So I'm going to talk a little bit about today about, as a team, we have a lot of folks sometimes on the scene of a call. And I'm going to hone in on a particular subject that I think, there's always work that we can do on it, and there's always improvements that need to be made in this area. We do a pretty good job. I know Greg talked about a lot of things that we're doing really well. This is one of the things that I think we could work on a little bit more. I've been here for a short period of time now, and so far we do okay with our airway management. That's particularly what I'm talking about. We do okay with it, but I think we've got a lot of room to grow and improve on how we're managing our airways. And I'm giving this talk because it starts with our first responders in particular, okay? You guys, first ones on the scene, it makes a big difference on what happens if you guys are effective and successful with the treatments that you guys provide. So very important that you guys are given all the tools and have the knowledge to be successful at this. A home is only as good as the foundation you build it on. Well, same thing with medicine. The advanced maneuvers and techniques are only good if the basics were working. You can't move on to advanced stuff if you can't get the basics to work right. So that's kind of where you guys come in. You guys have a unique role and a specific capability, and I want you guys to own it, So like I was mentioning, airway management before, and another thing I like about you guys is you guys can help keep my paramedics honest, okay? Before they try to move on to advanced airway, because there's only one person that can intubate unless there's two paramedics on scene. Before they can intubate, we have to make sure that we're able to ventilate this patient with our basics, okay? Basics, I mean bag valve ventilation, okay? If the basics aren't working, you don't need to worry about getting to your advanced maneuvers, okay? If you can't bag this patient with your basics, you do not pass go to your advanced. Well, why not? That doesn't make any sense. If something's not working, you should try something else, right? Well, what are you gonna do when you say, okay, fine, the basics not working, McCarty's gonna intubate this patient, and then he gets in there, oh crap, I can't see anything, this is not good, and now your advanced airway maneuver fails too. You didn't establish a basic that was working to fall back on, right? So now what are you gonna do? You're gonna be doing CPR on this patient when you bring him into the ER. So that's why it's very important that we establish and become successful with the basics before we move on to the advanced airway, okay? And there's a couple of things, you have of course, your BDM ventilation, you have your OPA, NPA, you have your iGel. So there's more than just a bag that we can do to make sure that our basics are successful. And then you know what? If the basics are working, do you need to move on to an advanced maneuver? Or do you load them up and get the heck out of Dodge and get them to the hospital, right? So if you need an advanced maneuver, you need it. But if you're doing the basics right, you know what? All of a sudden, that patient that was satting 60%, now you got them satting at 100%. Now they start waking up, they feel better, and all right, man, we're gonna get you to the hospital, or sir, we're gonna get you to the hospital. So, don't fall into that trap of, okay, this is turning into a panic situation, my basics aren't working, I need to go ahead and try to intubate this patient because it's not gonna work out well either, okay? Airway management. So when you guys, and this is just a solo topic that I'm going to focus on for this CE, but when you guys get on the scene over respiratory distress or any kind of respiratory call, this is some of the things that I want you guys to do. I want you guys to shoot for a goal of an O2 sat greater than 95%, okay? If we're gonna have to intubate, let's say you're 30 minutes away from the closest hospital and you're gonna have to intubate this patient because, well, you could bag them, but maybe you should intubate a patient if you're 30 minutes away. But let's say you have to intubate this patient for whatever reason. You want that O2 sat to be at least 100% for at least 3 minutes before anybody opens that mouth and tries to look, okay? So So you got old paramedic McCarty in there. You got the sat up to 89%, and he's like, move, let me try to intubate him. You guys tell him, hey, back up. That O2 sat's not above 95%. You're not going in there yet because it's not ready. It's not time yet. Okay. Another thing you can do is, and this is a freebie. Okay. Don't ever forget about using nasal cannula. Put the nasal cannula on and put it on 15 liters. High flow nasal cannula is freebie. That's free oxygen. Hands off. You don't have to do anything, and it's supplying oxygen to that patient, even if they're not breathing. What happens is that oxygen is getting blown into their oropharynx, and it gets sucked into the lungs because there's a gradient there. There's a lack of oxygen in the lungs. That gradient forces that oxygen down to the lungs. And if you're bagging them, you're gonna push that oxygen into their lungs too. So always put that on when you got a super hypoxic patient that's, out of it, not breathing on their own, and has a terrible O2 sat. Let's say you've done all this and your paramedic decides, okay, they're gonna intubate, and you guys agree this patient needs to be intubated. Keep an eye on that monitor, okay? The paramedic's job is to look strictly in the mouth and look for the cords, nothing else. But the O2 sat, keep an eye on that O2 sat. And you're starting off at 99%, call it out loud to them. That way they're not worried about what's going on. They hear, okay, my O2 sat's good, I'm still doing good. But as soon as you hit 94, all right, it's time to stop, needs to pull out, and you guys say, hey, 94%, we need to pull out, and we need to start bagging. And you need to get that O2 sat back up to 100%, okay? 3 minutes seems like that's a long time, man. This guy's crazy. He's talking about staying on scene for 3 minutes to get this O2 sat up. If you're gonna intubate a patient, then you better spend that 3 minutes to get that O2 sat up, okay? Because 3 minutes, why 3 minutes? Well, that's about how long it takes to wash out all the nitrogen that's in the lungs and get nothing but oxygen in there. And that's what you want, because when you go to intubate a patient, what do we give them? We give them something for sedation, and we give them a paralytic. And we're basically, artificially, we're killing that patient when we do that, right? Because that patient can't breathe on their own, they can't do nothing on their own anymore. Once we push a paralytic, that's it. That patient's life is in your hands. So that's why it's extremely important before we even take that step that these basics are working and that we've established that we're going to be successful with these basics before we move on to anything more advanced, okay? And 95%, well 95%, that's not that low. Why are we waiting on 95%? So take a look at this chart right here, okay? Some of you guys might have seen this before, but those of you that haven't, look at this chart, okay? This shows you several different types of patients. It shows you an obese patient, it shows you a pediatric patient, it shows you a moderately ill patient, which is probably what we're gonna be dealing with, right? We're not just intubating normal, healthy adults. They're probably pretty sick if we're looking to intubate them and manage their airways. So take a look at this chart here, okay? All these folks, it shows you if you have an O2 sat of 100%, it shows you how long it takes for them to desaturate, okay? This is minutes down here. And if you look at them, the obese patient, the pediatric patient, the normal adult, they can keep their O2 sat going at 100% for a pretty long time, right? But look what happens. When you hit 95% on this patient, you're on the steep side of this curve. It drops off pretty quickly. On the pediatric patient, you hit 95%, you're falling off pretty quickly. Even on the normal adult, when you drop to 95%, look how quickly it drops from there. You don't have a lot of time if you get below 95%. It's gonna start dropping on you very quickly. So don't get in that habit of, anybody ever been to Vegas? You ever been down to Vegas where you're like, oh man, one more hand, I think I can get my money back. One more hand, I think don't fall into that trap of, oh, it's 94%. Oh, I just need like 5 more seconds. I can get it. Let me get 5 more seconds. Just don't do it. Pull out and start bagging and get that O2 sat up to 100%. And what's the other thing that, I'm sure everybody in here has bagged a patient, right? When you have a patient whose O2 sat is 75% and you're bagging them, how long does it take to get that sat up to 100%? It doesn't just come up with 5 puffs, right? It takes a while. It takes a while. I mean, you got to work hard to get that O2 sat up to 100%. So, it's pretty easy if they're at 94, 93%, you can get them up to 100% pretty quickly, but don't let them fall below that because you're going to be in trouble. The other thing, why am I telling you, well, if you can't bag them up to 100%, then we need to intubate? Okay. All right, smarty guy, Nick. You think you're going to intubate a patient? Let's just take a normal patient here, okay? I'm going to take a normal patient here. you got him bagged up to 85%, right? You got him bagged up at 85%, and you're like, okay, it's not working, I'm just gonna intubate him because that's about as best as I can do. All right, so 85%, you go in there, and this is what? This is about 8 minutes, and is that about 20 seconds? About 20 seconds maybe? Sure. So in 20 seconds, you go from O2 sat of 85 down to 80, okay? And then in another 20 seconds, you're down to 75%, okay? And then you go another 10 seconds maybe, you're down to 70%, okay? And then in another 10 to 15 seconds, you don't need to be worried about intubating them. You're gonna be doing CPR on this patient, okay? That was what, less than a minute? So roughly in a minute's time, you dropped from 85 down to 65. You dropped your O2 sat 20% points. That's why you, instead, if you had bagged that patient up to 100%, look how long he would have had before that O2 sat even dropped to 95%. In a normal adult, that patient would have kept his O2 sat up for almost 7 minutes there before it started falling. But let's say, well, we don't have normal patients. You just said that, we're not gonna be intubated. All right, well, let's take this moderately ill patient, okay? Yeah, you did a bad job. You couldn't bag that patient up to above 95%. But let's say, you know, you got them up to 94%. Even if you got them up to 94%, look, you got a pretty good time window right there to get this patient intubated. That's 4 minutes, you know? But our goal is to shoot for 100% because you want as much time and you want to put the patient at the least amount of risk as possible, okay? If you can't get it up to 100%, then I would say just keep bagging. You got it up to 94%, hey, that's good enough. Get the heck out of Dodge, okay? I mean, you know, 94%, I don't know, it must have been TPD or somebody bagging them, right? I'm kidding. So what do you do? Okay, so you got that patient 94%, you guys get on scene, TPD, can't get that patient bagged up to 94%, you guys get there, you're like, move, let me take over, let me show you how it's done. So what do? That O2 sat's not coming up to 100%. Well, the first thing, and this is what everybody needs to be using this device. You guys aren't carrying it in your bags currently, but EMS has these in their bags, and this is what you need to ask for. If you're bagging a patient before EMS gets there, first thing you need to tell them is, hey, give me the PEEP valve, okay? You guys ever seen this thing? You guys better, have y'all ever worked with a PEEP valve? So this is a PEEP valve. Let me show you what it does. Let me pass that around. So what it does is it adds pressure to every bag that you squeeze. When you give a ventilation with the bag, what that does is it helps to put more air into that lung. And that O2 sat that wasn't coming up, that you could get up to 85% but couldn't get any higher, you put that thing on, and that O2 sat's going to jump up to 100% now. I got a little video here. Let me show you what I mean, what it does for you. So you're telling me this guy's going to get paid because I used his YouTube video? So this is just a normal bag, okay? Look what happens. I'll rewind it so you guys can see it. It's kind of a quick video. So this is with the PEEP valve, okay? Look at that lung coming out of the chest. Look how quickly it inflates. Let's try it again. So this is just a normal bag. That lung inflates and it completely collapses. It inflates and completely collapses. He puts the PEEP valve on it. Watch what happens. That lung inflates like it's supposed to. And that's the difference between, you can only get that sat to 85% to 100%. Watch one more time. Normal bagging right here. And this is with that PEEP valve. That's the PEEP valve right there. So it makes every squeeze of your bag that much more effective, okay? And now those patients, you know, they got terrible pneumonia, they have edema in their lungs, there's fluids, a drowning victim, whatever. What that does is it helps inflate all those parts of the lung and helps you get oxygen in there, and then get that O2 sat up. The other thing you're gonna do, this is obvious, you know, NPA in your OPA, right? Put in an NPA, put in 2 NPAs, put in 2 NPAs and an OPA, right? Who said you can only put in 1? Put them all in if you have to, okay? Get a good seal, okay? use 2-person BVM, 1 person to hold seal, 1 person to bag. Okay? Put in the eye gel. All right? If you're trying to bag this patient up, you can't get that O2 sat above 95%. Okay, what are we gonna do? Well, first of all, we're not gonna intubate that patient. Second of all, let's say you're at 85%, you're doing all of this, and you can't get that O2 sat up. Put an eye gel in and use the eye gel to ventilate the patient, okay? If the bag's not working, you can put an eye gel in. And this is for the paramedics. If you guys don't know, and this is something you guys are already dealing with this, ask for it. A lot of times, well, doc, we put in an eye gel, but the patient's gagging and throwing up. He wasn't tolerating it. So we had to go try to intubate. Well, what we did is we added a ketamine dosing specifically for that, okay? So there's a 1 milligram per kilogram dosing of ketamine that you can give to help the patient tolerate the eye gel so they're not gagging on it. They're not, trying to pull it out, choking on it and whatnot, because it does happen if they're just awake enough to where they're not gonna tolerate it. So give them the ketamine dose and put the eye gel in, okay? And now, if the patient is able to saturate up to 100% and you're able to hold it there, now you've already given your sedative. If you look like you're gonna try to intubate them, now you've proven that, okay, if everything else fails, this eye gel is working and I'm getting fine, you know what? You can stop right there and go, okay? But let's say you're half an hour away and you need to get a definitive airway. Okay, well now you've already given the sedation, you're ready to RSI. Now you can push a paralytic and you can intubate the patient. And hey, you know what? If you get in there and you can't see anything, you already proved to yourself that the eye gel was working. Fall back on your basic maneuver, that's gonna fix it. And then don't forget your freebie. Put that nasal cannula on, turn it up to 15 liters. That's free oxygen. Don't ever give away anything that's free, okay? So the other thing, wow, we were doing all that stuff and the patient still, we couldn't get that set up. Okay, well the other part is you have to position your patient properly, right? You tell me a respiratory therapist in the hospital is gonna help bag you guys, You're gonna let a respiratory, how come the respiratory therapist can get the O2 sat up to 100%? Because I don't intubate anybody unless the sat is 100%, okay? So somehow the respiratory therapist does some kind of magic and gets that O2 sat up. You guys can't get the O2 sat up? You guys even bag, bro? Is that what y'all saying? So it's about positioning, right? So if you don't have any kind of neck injury, okay, you got a trauma patient, you don't really have a choice, but not all of our patients have traumas, particularly not these respiratory distress ones. You need to open up that airway. You need to maneuver their head into the right position, right? So look what happens. This is the problem with managing an airway. We have a 90-degree angle that we have to overcome in order to intubate a patient or to even push air into the mouth and then into the trachea, right? That's a 90-degree angle. I mean, that just doesn't work right. Well, if you put a little bump underneath the patient's head, let's say a towel roll or something, look what happens. These angles, they line up a little bit better. Here's your line of sight right here, and this is your laryngeal view. It helps line it up a little bit, but not that great. But then look what you do. You put a bump under their head, and then you tilt their head all the way back, okay? The head tilt chin lift, right? You heard of that one? And now look what happens. That oral axis and the laryngeal axis, they're not perfectly lined up. I think it's impossible to do that, but they're lined up a heck of a lot better here than they are right here, where they're almost at a 90-degree angle to each other. You see that? So don't forget to position your patient's head. Open up that airway. Tilt their head back and put their chin up in the air and line up their oral and nasal cavity with their larynx. Okay, that's another thing that's going to help you. And then don't forget to ventilate your patients properly, okay? Sometimes in these situations, it's crazy, it's hectic, and there's all kinds of stuff going on, and we're sitting there bagging them at the same rate as what our heart rate's going, and that's not really good. You want to slow down. Don't forget to breathe for the patient the way you're breathing, okay? If you're breathing too fast, all right, try to slow yourself down. That way you have a clearer thinking of mind. But keep the patient 10 to 12 breaths a minute, okay? Don't overbag the patient. Some people, and a lot of people may not realize this, but our ambu bag, it has a capacity, the volume of the ambu bag is 1,500 milliliters. I don't know why the heck it's got so much volume in that bag, because a normal adult has a lung capacity of 500 milliliters. So you don't really have to squeeze that bag like you're balling up a piece of paper or something, but just give it a half squeeze and that's usually good enough. Some people even advocate for the use of pediatric ambu bags in adults, because the pediatric ambu bag is about 500 to 1,000 cc's. So I'm not sure why they make such a large capacity ambu bag, but just remember that. You don't have to squeeze that whole bag to get air into the lung. I want to talk a little bit about capnography. Capnography, it's at the bottom of the LifePak monitor there, and it's something that's extremely useful. That's something that, I want you guys to make sure that we're using on every single one of these patients. Whether you're bagging them, whether you're putting in an eye gel, whether you're intubating them, put that capnography on. If it's not on there, don't move until you put it on, because it's going to help you manage how you're going to ventilate that patient, right? A lot of times you guys are going to be the ones that are handling the ambu bag, right? Whether it's an eye gel or whatever. You want to keep that end-tidal CO2 between 35 to 45, okay? So if it starts going up too high, you're bagging too slow. They're building up carbon dioxide, and that's why it's starting to go up. So you want to bag a little bit faster, okay? If it's too low, if it's below 35, that means they're blowing off too much carbon dioxide. Slow down a little bit, okay? Try to keep it between 35 and 45. Another thing, how many guys do chest compressions in here when you get to see cardiac arrest? So this is the other thing where it helps, okay? If you have your end-tidal hooked up, we don't have these little mannequins with the lights and the alarms that tells you, yeah, you're doing it good or you're not doing it good enough. This is what you can use. You want to look at your end-tidal CO2. When you're doing chest compressions, you want to shoot for an end-tidal CO2 of greater than 10, okay? If you're doing less than 10, all right, that means it's time to switch. You're getting tired, or you need to push harder, okay? If it drops less than 10, you also want to make sure that your airway hasn't become displaced, or it just hasn't become disconnected from the monitor. But you want to shoot for a capnography of 10. If you're looking at the LifePak, it's the number that's in yellow all the way at the bottom of the screen. You don't have to worry about the waveform for now. Just look at the number and make sure you got it above 10 when you're doing chest compressions. And you're doing that patient a favor if you are, okay? The flip side of the coin, when we have patients that are saturating normal, don't have low to, they're not dying, their respiratory, their airway, everything is fine, don't give them oxygen if they don't need it, okay? Too much of a good thing is also not good, right? Oxygen is considered a medication, it is a drug, and too much of oxygen is also not good, especially if you have a normal breathing, awake and alert patient who's saturating above 94%. You don't really need oxygen on these folks. So I know the chest pain, it's always, there's been an acronym for it, MONO, in which how you treat chest pain patients: morphine, oxygen, nitroglycerin, and aspirin. But they've kind of gone away from it. The aspirin and the nitroglycerin are kind of the only two things that are left. The oxygen, what they found is a lot of these chest pain people, their O2 sats are normal. They're just having pain. And when we're putting them on oxygen, what it does is it creates free radicals, and it actually causes harm to any tissue damage that they already have. So you want to avoid oxygen if their sats are above 94%. Morphine, you can give some morphine, but the problem with morphine is you might bottom their pressures out and you might get yourself in a really bad situation. That's why they don't really say give a lot of morphine to chest pain patients anymore, okay? COPD patients, that's another area where we can potentially cause some harm to folks with oxygen. So COPD patients, they've trashed their lungs are damaged. Some of them normally saturate at 88, 89%, and that's normal for them. They don't use oxygen, that's what they are at, and they're happy at that normal oxygen sat. If they're having an exacerbation of wheezing, that oxygen isn't really going to fix that, albuterol is. So putting an O2 sat, if they're normally at 89%, is actually going to harm them, because what happens is when you give a COPD patient too much oxygen, their body is like, man, I got all this oxygen, man, I don't need to breathe so much anymore, and they go into what's called CO2 narcosis, okay? Their breathing slows down to the point where they're not blowing off this carbon dioxide, and then they become very lethargic, and then they end up needing to be intubated. So if you get a COPD patient, you see, oh man, the sats are like 88, 89%, ask them, hey, do you know what your normal oxygen saturation is? A lot of them will know it. Some of them may not. If they don't know it, aim for an O2 sat of about 90 to 92%, okay? Nasal cannula, you probably don't want to go too much more than that. But 90 to 92%, if they don't know what their O2 sat is, will keep you safe. It'll keep the patient safe. It'll keep them breathing on their own and keep them from going into any kind of CO2 narcosis or becoming lethargic and somnolent on you, okay? That's all I got for you guys. What kind of questions do you guys have? Somebody asked yesterday, go ahead, who is it?
Does our current BVM have an adapter port for this to go in there?
Yeah, all BVMs do. And so, and if you look at it, you turn the little red knob, and you want to set it between 5 to 10. You want to start at 5, and you can dial it down to 10 if you need to, and that just gives you more pressure to get that lung inflated.
Pediatrics, same way?
Pediatrics, rarely do you need them, but yeah, if you peds, you probably don't need more than 5. Yeah, 5 is the lowest it'll let you go on it, but yeah, you can give them a PEEP of 5 because the peds, you know, they don't have CHF, they don't get pulmonary edema and all that, but if you got a drowning kid or a, you know, like a cystic fibrosis kid that's got a terrible pneumonia, his lungs all consolidated with infection, that's where it'll help you. So, and then the way, and I'll show you guys when we go do some practice here, but at the tip of the bag, there's like a little plastic vent piece, a little rubber piece. It pulls right off and just cap it right on. So it basically goes on the.
Is that something we can get in their airway bags?
I think so. I was actually back there asking what's the cost on those things. I think they're pretty cheap, and if they are, that'd be something that'd be very useful for you guys to have in your bags because it'll make a big difference, as you saw on that video. Big difference. What other questions we got? Anything else? No? All right. I think we're break.